I had wanted to wrap up the last 3 days with a discussion about face transplants, and from the moral and ethical questions, because I'm no doctor and I wouldn't know one suture from the other. And I think Jonathan began to raise these rather delicate issues, because what nobody seems to tackle, even if technically you can do it, there are 3 aspects which I would like you to discuss at speed, because our president says speed. We have to discuss first the impact on the recipient, the life-changing effect of having somebody else's face. It's not like having a heart from somebody else, although that some people argue will have an impact. But number one. Number two, the impact on the donor, although he is dead most probably, but he is dead, sorry, or she's dead, but the problem is the family of the donor. If you have an operation of this kind, when the person is walking in the street, in the community, is the family of the donor recognizing their friend or relative? And thirdly, does this lead to a complicated series of emotions? Because the family of the donor may say, oh, well, I know this man or this woman. And the third, slightly more complex issue, which I don't know if any of you have tackled this yet in your ethics meeting, what if the recipient says to you, I want a face of a younger person than his age is, or her age, or I want a different gender or color? Well, so I throw all this to you guys because at speed, and I would like you, sir, with the bow tie, because you're obviously distinguished since you have a bow tie, to start the discussion.
I think if I could come to the second point that you raised first, which is the donor, the family of the donor. I'm going slightly off piece, but there was a fascinating article in PRS recently on how the body of the donor is prepared for the family to look at. Now, I had always imagined that the rest of the family would not like to look at the donor, that once the face had been removed, the family of that individual would have a closed casket, as it were. But there was a fascinating article there that the family do actually want to look at the body of their loved one. And how do you prepare that? They were preparing a series of masks to look like the original. In other words, they would take a death mask, so we're back to taking death masks, and they were creating a death mask for the donor so the family could look at it. And it was an extraordinary paper. The early ones that were produced were not particularly realistic because they only replaced that part that was removed, and they found that they get the best result if they in fact create a mask of the whole face. So prior to donation, a mold is taken, a face mask is created, and then that is replaced over the cadaver so the family can have, as the Americans love to say, closure. But it enables them to see their loved one intact before the body is cremated or buried or what have you. And that is something that never factored into the equation.
Barry, thank you. Can I ask Jonathan to add just one word?
If we look at the effect on the person, when the first ones came out, I don't know, Isabelle Dinois, in a Sunday Times article said, well, I don't call that my face, it's both the other's face and my face. But I suspect as it becomes more long-term, it becomes more her face. There were also articles saying, and again, James Partridge wrote one saying, careful, because visible difference does not mean it always has to be corrected. Why can't we accept visible difference? But against that, many of the people who've had face transplants led very poor lives with little or no social interaction, and their lives have been improved hugely by the facial transplant. So that's a very strong ethical reason.
Could I ask Sam, and then I'll go.
Sure. I mean, I echo really what Barry said at the Skull-Based conference this year. They presented from France, and two things struck me. One was the mortality, they lost 2, and the second thing was in fact the death mask, because I mean I'm pretty hard actually, but I found the donor site pretty upsetting, even remotely in the audience watching it. Okay. I mean, having said that, I'm not in the people to ask, I think, are the recipients, because I'm always teaching my opportunities to have a plan A, plan B, and plan C. And if you have no plan B, if you have no face, I think a lot of these intellectual discussions are a little bit removed from where you actually want to be.
The recipients don't regard their damaged face as their own face anyway. And so they're coming from a position where their original face has been effectively lost. They have a different face as a result of the injury, and then it's something towards their own face afterwards. So I think...
Can I throw the question open to our wonderful guest? Sir?
You probably recall the first meeting we had where people were having facelifts, and we had people from the beauty industry, from the film industry and everything. They were flinching when they saw the surgery.
Yes.
How different are the perceptions of the people who are looking at lost whole faces and going for a new face? How is that different? Or is it just one end of the other spectrum that somebody would be prepared to put themselves under surgery for an improvement in their appearance?
Right. Because of the time constraints, can we ask 2-3 questions at the same time? Any other contributions? Yes, please.
I'm Colin McKeever from Glasgow. I spent a year in Paris in the face transplant unit, and just some comments on some.
Can you speak up a bit?
Certainly, yeah. Some comments on some of the questions and some of the answers actually. I was part of the team that wrote the article that you're talking about with the death mask. Part of the ethical approval in France is that you must restore the donor, and you must restore them to a standard that's acceptable for the family. We carried out a survey of the families, and they were all found that the restored donor was acceptable to them. Also, because of the small number of cases, they're always going to be in the media, and there's a woman who donated her husband's face in the States, who wrote a book on the experience of it, and she is very much in favour of the support that she had and the fact that she feels that she's able to do something for someone else. I think they're very complex emotions, but I think what David said is very true. The extent of the injuries that these patients have had, the quality of their lives have been very poor, and actually dealing with what they get is actually probably more straightforward than we expected it to be in France anyway. There have been 2 cases that have died, one in France, one in China. There's been 23 transplants so far in the world. I can talk about the case in France, in our unit, where we did full face and bilateral hands at the same time. And I think the huge immunological hit of that was probably more of a problem than actually the technicalities of the face transplant.
Oh, thank you. Who would like to respond to either of the 2 comments?
I mean, Colin, thank you. I think that those papers were I think, seminal. But the paper in Paris that was recently delivered at the International Skull-Base Congress, the World Skull-Base Congress in Brighton, I think that the state of the pre-morbid anatomy was such, and Jonathan alluded to it also, that we're dealing with end stage. These are people who find it almost impossible to get out of their home. And one particular case was very moving. A gentleman with, I think, extensive neurofibromatosis. He got out and about, but almost stopped the traffic because of the extent of his disease. And the transformation that took place there was quite extraordinary. And I think that the recipient, the presumed concern that the recipient may have with their new face, I think, is more than offset by the huge shift that it makes just to be able to go out. And the transformation in these individuals is quite extraordinary. I was very skeptical of face transplants, but having seen the results, particularly from the Paris group, I'm a convert. And what saddened me in the work that you were doing there is clearly a group that cannot be treated. And I think the burns, where the tissue damage is so great that they're beyond hope. which is a dreadful place to be when you've had the door opened for hope and then have it slammed shut again, I think is even more difficult for that group. But I'm a convert to this now, having been very much a skeptic at the outset.
Please, yes.
Could I try and address Austin's comment really as to whether this is two ends of a spectrum? Perhaps one way of looking at it would be to say that the patient with the very minor physical problem who might have a debilitating psychological problem that prevents them going out. And we've all seen these patients. My nose stops me going out, stops me getting a job. If you just did my rhinoplasty, I would be fine. And at the other end of the extreme, we have someone who has a significant physical abnormality to their face such that they can't go out. They're both, and they have a psychological response to that as well. So you have psychological pathology or response, whether it's pathology at one end, and massive physical abnormality or deformity at one end, and small physical ability and psychological massive abnormality. And these lines must cross somewhere in the middle. And it's with the patients where the balance is difficult to work out where they fit, what to do in the middle. So I guess it might seem provocative and trivial to say it's on the same spectrum, but I think it is. And it's the patients in the middle that provide the complex problems.
Well, Nikki Ramsey, when she started at UE, found not a huge relationship between the physical difference and the psychological response to that. And of course the skill is, as you've suggested, is to decide where it lies on that continuum, so that for some people you might correct their physical change, condition. I'm trying not to pathologize it, but it won't make any effect at all.
Can I pose a slightly more complex and perhaps more difficult question in some ways? How do you choose the recipient? What's the criteria? I mean, have these, especially our colleague there at the back, have these issues been dealt with? Because like in heart transplant in the early days, there was some criteria, for example, for being, who qualified for being a recipient. If you are 18 with a heart attack and if you are 80 with a heart attack. I don't know if there is any criteria and if our audience would like to participate on this topic. In other words, is there some criteria? Who should decide on who should receive the new face? Perhaps Simon could deal with that. You look very ponderous.
Just thinking about the only patient I've met who was eligible one really was a chap who put both barrels under his chin, previously psychiatrically damaged, psychologically damaged, and was probably the least capable person of managing one. And we've had to manage him with scapular flaps and really local surgery. I think the problem that I anticipate that the two major categories are burns, which Barry mentioned, within trauma, and also massive injury in the civilian practice is largely self-induced, and you're going to be struggling a bit with dealing with the capability to take anti-rejection medication, etc. So for me, I think it's a very difficult one. Perhaps Colin has some ideas on it.
Are there any more questions from our wonderful medical audience? Yes, please.
Thanks for your talks. My name is Gerard Gillen, Registrar in Derby. Obviously, the facial transplant movement and things is quite fascinating, but I just wondered, it's a question to the panel and to obviously some legal experts in here as well. Is there an argument for a sort of, not so much a witness, but a recipient identity protection scheme here? Because clearly anyone who's undergone a facial transplant is going to have, some quite traumatic psychological issues, and then suddenly, to get their facial transplant, they'll be catapulted into the media spotlight. And we know that even normal celebs can't cope with that, yet we are expecting these people to cope with this. And is there an argument that once they've had the face transplant, they should, to some extent and for some period of time, be allowed some anonymity until such times as they feel ready to come out into the open?
I think that's a fascinating question. I don't know if Barry would deal with it.
It's a very good idea, and I think it should be encouraged. And the problem is, I guess I would imagine the first face transplant done in France, you wonder whether the patient actually agreed to be interviewed or whether they were thrust into the limelight. It's not that long ago, well, not for me anyway, going back to Christian Barnard's first heart transplant. The first gentleman, I think, was Wyshansky. He died, and then Philip Bleiberg, the dentist, was transplanted. And both of those patients were not celebrities, but they were both out internationally in a short space of time. And I think one of the problems with the early face transplant recipients has to be that it would be very difficult to guarantee anonymity. Subsequently, I'm sure as this becomes more common, anonymity would be, the patient's identity should be protected. Colin, in Paris, how do you handle this? You've got more experience than any of us here, having worked there.
It's almost impossible to guarantee anonymity. It is part of the protocol that we have to guarantee anonymity, and I know within the UK we've kind of explored that as well. And one of the big concerns from the transplant surgeons out with composite transplant is that organ donation generally will be affected by the negative press that will come from the loss of anonymity. So I think it's something that has to be built into a programme, and I think it's very, very difficult to do. You have a large team involved. It's an unusual operation, and guaranteeing anonymity, I don't think you can do it. I think you have to control it. I think that's the only way you can do it, and that's certainly what they do in France. The hospital media unit organise a conference 6 months after the surgery. Usually it happens before then, though, because there's been leaks.
Thank you. None of my panel has answered the slightly more challenging and more difficult question of the recipient who insists, for example, on the type of face he or she will get. And what if, for example, the face that's available for the transplant is in terms of skin color, for example? I mean, how would you deal with that? Let me ask you.
I don't know how they do it. I presume that any surgical program would have a facial donor who's equivalent of skin.
But my question is, should it be?
I would imagine that's something that is particularly pertinent to the person having the face transplant.
So you'd leave it open to the recipient?
Well, I don't know if it occurs, but you have to realize these people are living at home they're not able to become social, they're having a miserable time. Now that makes them more vulnerable to having a face which may not be ideal for them, possibly, but equally well, they're very strongly motivated to want to improve their lives. So again, it would be back to Colin, I'm sure.
But before Colin answers, are there any questions about the technical aspects of any of our colleagues?
Barry in the front row here.
Barry.
Yeah. Barry O'Regan, sorry. Could I raise a slightly discordant question? In the context of all the other problems that exist across facial surgery and our experience of it, is the professional focus and the public focus on facial transplant not quite potentially damaging and disproportionate to its ultimate long-term use? I find a strange disproportion between the amount of media attention and other attention and what it ultimately is likely to do for a very small number of people.
David, can you take that?
I guess I agree that there is a disproportionate amount of media attention. However, it is a technique that offers some hope for a very small group of patients for whom we're unable to offer anything else. They're patients who sit at home, often nasogastrically or with a peg tube fed. They have no social life. They are completely isolated. And lots of things are making them survive their initial injury or condition, and then they're left with no hope. So just because the media response is excessive and inappropriate in some cases doesn't mean to say it shouldn't go on.
My suggestion was not that it shouldn't go on, it's that it does attract a slightly perverse attention and disproportionate focus to the potential distraction from many other equally distressing and important areas of surgical activity.
There are other operations and other treatments that may have a similar improvement on the person. The reason, coming back to why face transplants are in the media so much, is it's this relationship between self, identity and face, which fascinates, and that's what it's telling us. And the idea that you have a face transplant, you become a different person or something. Well, we're going to get beyond that, hopefully, but it'll take education, that people will begin to see that the person is the same person. You've got to look through the face to the person, basically.
I think, can I come back to one original point that you made? What about resemblance? And again, probably Colin, but originally I envisaged, and to an extent the early face transplants were soft tissue, we were transporting a soft tissue envelope. But the cases that are being reported now, and the extent of the mobilization really of the zygomas, the maxilla, the mandible, suddenly we're getting closer to transporting an identity than a face mask. And I'm not sure, it would be interesting to see how close the recipient is in some of these cases when we're transplanting all of the lower third and middle third, or a significant portion of the lower and middle third of the face, including soft tissue, including eyelids in some instances, I think. The results are extraordinary, but how close are these going to be to resembling the donor? Colin, what's your view on this, in view of the extent of hard and soft tissue transplantation?
The last two that we did were Lefort 3 level with mandible at the level of the angle ramus, and looking at the donor's face and the recipient's face, they're still early. They're still only a year down the line, but the soft tissue doesn't look the same. They don't look like the same person, and the movement is different. Just the facial tone is different. And one of the things actually in one of the talks you commented on was the facial nerve function. And the one thing we've been surprised about has been how good the facial nerve function actually is. And part of that is the immunosuppression that they take that's neuroregenerative. And all of them have very good facial nerve function, but it's disproportionate on both sides.
I mean, the speed with which the facial nerve recovers, or facial nerve function recovers, it seems to me throws our previous ideas of nerve regeneration into a cocked hat. Would you?
Well, the facial nerves is different, isn't it?
Yes.
Do you get lots of synkinesis in these people?
You do, and our approach has changed because of the synkinesis we've had. You do have movement in individual branches of the nerve. However, you do also have some synkinesis, and we've gone from all the previous anastomosis have been on the facial nerve stump, and we're now going to try and do it on branches of the facial nerve to try and improve the movement.
Are there any more questions? Yes, sir.
Peter McDermott, London. I just put it to the panel. The first French case, I believe, correct me if I'm wrong, but she was heavily depressed. She was sedated with alcohol and a mixture of other sedatives. And the dog, her pet dog, tried to wake her up by savaging her mid-face. And when she finally woke up, she realized that she had catastrophic damage. And the recipient, I believe, or the donor, I believe, was a successful suicide attempt. I'm just put it to the panel, what do they think the psychological effects are? Once she's got over the initial euphoria of having another face, then with the realization that the face she wears is actually somebody who committed suicide successfully. Do you think this is a good recipe, or I just put it to think about?
Can I ask Simon to deal with that?
Well, I echo my comments previously about the few patients I've seen who are totally in no way, shape or form able to receive it. I mean your points are well made. I imagine the psychological support and the psychiatric assessment of these people is legionary.
Right. On this wonderful note, I would like myself to thank this wonderful man, Ian, for bringing me to get rid of my fear of medicine. Thank you very much for organizing a wonderful function.